This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Well, welcome to our podcast on cardiovascular health in women. And with me, we have a very, very special guest all the way from Australia, a cardiothoracic surgeon and adjunct senior lecturer at Curtin University. She's also an author. She's on TV, but really, I think the most important part is that she's very passionate, a passionate supporter of women's heart disease advocacy. So, Nikki Stamp, thank you very much for taking the time and being with us here today.
No, thank you. Thank you for having me. It's a long, long way away.
Yes, it was a bit of a challenge, trying to hook up together with the time zones. It's so confusing.
Yes. It's always difficult. So we just, we learn to roll with it down here.
Well, we know that women undergo important changes in sex hormones throughout their lifetime, and that can impact cardiovascular risk. Whereas traditional risk factors dominate in older age, there's several female-specific risk factors and inflammatory variables that influence a woman's risk at younger and middle age. We know that hypertensive pregnancy disorders and gestational diabetes are associated with increased risk in young women. We know also that menopause transition has an additional adverse effect to aging, and that needs special attention to ensure optimal risk profile and quality of life. So, 20 years ago, Nikki, we had this awareness program, and we had a special guest. It was Lucie Arnaz. As you know, she's the daughter of the most famous American couple, Lucille Ball and Daisy Arnaz.
Yes,
they're known as Ricky Ricardo. And in those days, obviously, we presented things about women and heart disease. Mostly, it was about symptoms, how symptoms are different, but we didn't know very much. Of course, it didn't matter because people came mostly for Lucy. Here we are 20 years later, and I'm wondering whether you could maybe kind of give us a little bit of a breakdown on heart disease in women overall, talking a little bit about risk factors and where are we now in 2020?
Yeah, I think that's a really important point that you've raised, that this kind of awareness, both in the public sphere and amongst healthcare professionals, is relatively new. So, for example, when I went through medical school, we were never taught that there is any sex and gender differences in heart disease. In fact, in a lot of cardiovascular disease and a lot of other diseases as well, we just didn't know. The research wasn't there. The awareness wasn't there by any stretch. But as you say, in recent times, probably in the last couple of decades, we've seen a bit of a breakthrough in terms of looking at heart disease or cardiovascular disease, because we can encompass things like stroke, aortic disease, peripheral vascular disease, all of that in amongst this, because there are sex and gender differences in that, that we've started to look at that. And I found it's really hard going to get this information out there. So from the research as it's come out, we've seen the Heart Foundation in the United States lead with the Go Red for Women campaign, which has done a really good job of raising awareness in the community about heart disease. Here in Australia, the Heart Foundation looked at the awareness of women themselves. I think I couldn't be misquoting this year, but about 5 years ago, something like only 2 or 3 out of 10 women knew that heart disease was something they had to be personally concerned with. And heart disease, cardiovascular disease, is the leading cause of death in women predominantly around the world. You are 3 times as likely to die of heart disease than breast cancer. But of course, breast cancer has such a wonderful public awareness program that, ischemic heart disease really hasn't had. So it is a major problem. We've also sort of seen a real paucity of women included in trials, in clinical trials. So it's around 30 to 40% of trial participants are women. So we don't have the information, we don't have the awareness. And I think the thing that people need to, particularly clinicians, need to understand is that heart disease and the differences between men and women it's a really complex biopsychosocial problem, and we need to be paying a lot more attention, because if there's one thing people take away from this, it's that women do poorly in comparison to men, and there is a big gap there that we have the ability to close tomorrow if we want, through very simple measures, and there's a lot of other stuff that is more complex that needs to be worked out. But we as clinicians need to be very aware that there's a lot that we can do just straight off the bat tomorrow.
Well, it appears that at least over the last few years or so, it's really coming in evidence that there are some certain characteristics to women's heart disease. And particularly, I think I wanted us to maybe kind of focus maybe on three main aspects. The first one being, heart attacks without evidence of coronary artery disease. The second one that we want to focus is about this coronary artery dissection or SCAD, and maybe the third one, the one that your book author is about Takotsubo. So if we take maybe the first one, we had a podcast, and we're probably going to publish it this week. It was with Dr. Janet Way from UCLA. And it was about patients that have chest pain or ischemia with no coronary artery disease, or so-called INOCA. And now we're talking a little bit about the same thing in women that present with heart attack, and you do an arteriogram and you don't find any coronary artery disease or any blockages. So how can you have a heart attack with almost normal or very mild coronary disease? So can we explain?
So this, I'll tell you, I'll give you a little story to illustrate how marked that can be. So a colleague of mine operated on a relatively young woman. She was in her late 40s for a coronary bypass graft. And after the surgery, she was having ST elevation. She looked like she was having an anterior MI. So she went straight from ICU to the cath lab, and the grafts were all down, but her coronaries were normal. So they went and looked at the pre-op angiogram, which showed obstruction. So it looked like she was having sort of dynamic obstruction rather than having fixed atherosclerotic plaque. So I think that it's important to understand that this non-obstructive coronary disease picture is much more common in women. It echoes very similarly, traditional obstructive coronary disease, but it is a real problem in women, and it is something that we're sort of learning a little bit more about, but we need to be a little bit further over because the treatment is different. Obviously, she probably shouldn't be having a cabbage, but or any sort of revascularization. But yeah, it is something that we need to know about. So we're talking about sort of people who don't have any stenosis, any fixed stenosis of their coronary arteries. So it tends to be much more common in women. It's sort of accounting for at least 65% of infarcts in women. And the reason that this has sort of come to light, apart from the fact that we're a bit more inquisitive, we have, fantastic coronary imaging techniques now. We have, IVUS and all these kinds of things that we can actually better look at and, assess coronary disease rather than just the old eyeball of, how blocked is this artery. But we've also seen that we've got this, in the community, we've got a lot more effective primary prevention and risk factor control. So people aren't smoking as much. We're giving aspirin and statins and other medications. So we're sort of reducing these kind of plaque ruptures. But in women, we are seeing that because of the sex hormones, particularly estrogen, which affects vascular reactivity, that we're seeing they're getting infarcts from basic, almost like hyperreactivity. So they're getting things like vasospasm. We're seeing things like thrombosis and, a propensity to thromboembolism. Microvascular dysfunction is a really important factor in women. Again, this really comes down to estrogen. So I guess probably one of the biggest questions is, what does that actually mean for women? Well, first of all, I think that my reading of the research around this is that outcome is debatable. So these women can present for all the world looking like they're having a very typical AMI. They can have ECG changes, they have symptoms, they might have a troponin leak. However, what comes after that is a little bit unknown. So there's a bit of argument in the literature as to whether or not this actually equates to poor outcomes or better outcomes than traditional obstructive disease. So some of the bigger studies have suggested that maybe non-obstructive coronary disease might do a bit better, where, you've got, like, I think, Alan, you mentioned to me the New Zealand registry where they have a slightly better outcome. But there's also been evidence from, say, Sweetheart registry, from Virgo study, where we're actually seeing that, they are having an equal or even sometimes a greater mortality rate than obstructive coronary disease. And I think one of the things that we can think about with that is that we've gotten pretty good at treating obstructive coronary disease. I think that's probably fair to say. We've got great medications, we've got great revascularization procedures, we've got really good at secondary prevention. This is a bit of an unknown. This is a little bit more difficult to treat. I think that we're kind of flying blind without as much evidence at the moment in these situations.
That's so true. I mean, I guess we thought years ago that coronary artery disease was basically just the same in men and women. They just presented differently with maybe just breath and nausea. But I think we're finding out that there's a lot more, to it than this. This phenomenon of having heart attack and no significant coronary artery blockages. They're very new, at least to the field. It's called also MINOCA. And
MINOCA, correct, yeah. And
you have these patients that come to see you afterward and say, well, I had a heart attack, but my doctor, they did an arteriogram, they couldn't find any, obstruction, and therefore it's kind of hard to know. I mean, are we at risk for recurrence? How do we treat these patients? We treat them the same way, as we treat patients with obstructive coronary disease. Certainly, bypass is probably not the best way. But
no, it's not.
Platelets, statin, beta blocker. Yes, these. We need to treat them as they had a heart attack. It's real.
Yeah. I think calcium channel blockers are another. We talked about this for years. Calcium channel blockers of nitrates, anything that sort of vasodilates the coronary circulation, is a really important mainstay of treatment. We love giving calcium channel blockers to anything that we think needs that. For example, that case that I mentioned that my colleague had, that woman got put on calcium channel blockers and she was fine. I think though, one of the interesting things that comes out a lot in probably all the different sort of cardiac syndromes that we see in women is this propensity for longer term symptoms in the absence of a diagnosable physical cause. So chest pain, anxiety, etc., shortness of breath. So I think that's a real downfall in our treatment for ischemic heart disease, MINOCA, for SCAD, and a few other things. So, this is a really interesting area of research. And, like I said, the role of estrogen in this just cannot be understated. Estrogen is such a fascinating hormone. The vascular reactivity aspect of this is probably a huge part. But, you know, we do see this in young women who theoretically should be having normal, you know, estrogen levels. But, you know, I think as we learn a little bit more about this, I think we're probably going to find out a lot more about the way estrogen affects this, and you know, probably possibly even, you know, is protective in this group if we take for example the fact that these ladies might do a little bit better. But I think this is a really early stage of research, but you know, still concerning. You know, I would definitely not want to be experiencing this myself by any stretch.
Agree. Well, as you mentioned, maybe about 4 to 5% of these patients, women presenting with a heart attack, we do the arteriogram, and when we find these coronary artery dissection, or so-called SCAD. Tell us a little bit about this. I mean, this is relatively kind of new that we're finding out what SCAD really is, and what is it exactly? How do we explain that?
Yeah, so SCAD, spontaneous coronary artery dissection. And I think the biggest take-home message for this is that it is the most common cause for an infarct for young women, so under the age of 50. So they also tend to be women who have no or very few traditional risk factors. So if you've got a 40-year-old woman who has no high cholesterol, no family history, but is looking all the world like a heart attack, she could absolutely have SCAD. So my biggest, the case for me that got me very interested in SCAD was a lady who was in her early 40s who dissected her left main. So she came in shocked, obviously, and my cardiology colleagues, you know, tried really hard to open this up, but couldn't, and we ended up putting her on ECMO, and then she got a VAD 2 days later and had to be transplanted. So that's very dramatic. It's a very dramatic way to have SCAD. But look, it's really fascinating. It's basically the debate is how this happens, whether or not you're getting the inside out or the outside in theory. So the instigating factor is thought to be either a hematoma in the tunica intermedia, which then pushes the intima into the lumen and causes obstruction, or there is a tear in the intima itself, like similar to a type A or type B aortic dissection. So the likely thing, though, that we think is happening is that you're getting this hematoma in the tunica intermedia rather than an intimal tear, because you don't find an intimal tear, and it also fits with the natural history of this. This is one time when we are not welcome in the coronary arteries. We don't want to be stenting it. We definitely don't want to be doing a bypass. You know, most of them will just heal by themselves with conservative treatments. So aspirin, beta blockers, those kinds of things. But it's very interesting. Like, this is by and large predominantly over 90% female thing. So obviously this is one of those things where we saw this happening in women and thought, oh, well, if it must be about sex hormones, and it possibly is. However, what's really interesting is that it occurs across all different, I'd say, hormone profiles. We see it around pregnancy, we see it after pregnancy, we see it before and after menopause, we see it on contraception. So, you know, where you've just got all these different hormone profiles. So is it related to estrogen? Possibly. Is it related to progesterone? Possibly. We're not really sure, but there is definitely a preponderance towards female patients. So a few inciting factors that we can see, you know, we see in pregnancy, although predominantly it's postpartum, usually in the first week after pregnancy. So I saw one of those at one of our multidisciplinary meetings recently. These patients tend to have a more severe form of SCAD, and emotional or physical stress, so exercising. Interestingly, the physical stress, and we see this in Takotsubo as well, physical stress tends to be more common in male patients, so I'm not sure the pathophysiology of that. And you might also see it associated with underlying connective tissue disorders, and probably the most common one would be fibromuscular dysplasia, which we would screen every single SCAD patient for with a CT angiogram head to toe, and you'll see that sort of like bumpiness of, say, the renal arteries and other sort of medium-sized arteries. So it can be quite nasty, obviously. My patient getting a VAD and a transplant is probably the very severe end of things. But, they have the same clinical presentation as a traditional AMI. The thing I always find the most scary for this is that the LAD is the most commonly affected vessel. So it's probably the artery you least would like to knock off. But anyway, so these ladies all go for a coronary angiogram, and you see, these very sort of, characteristic pictures. And the things that sort of make you think that this is SCAD rather than obstruction would be, normal coronary arteries and lack of plaque elsewhere. Getting these very typical pictures like the spiral dissection. That's not very common. The most common one is this sort of long, thin segment of tapering. Then it just goes back to a normal caliber artery. And things like, OCT or IVUS really useful because you can find that there's no intraluminal thrombus, because of course as we all know, the pathophysiology of a typical atherosclerotic infarct would be plaque rupture and then thrombus formation on top of that. So you're not going to see that here inside the lumen. So as I mentioned, we don't want to be intervening in this where possible, because both CABG and PCI have really high rates of failure. We can definitely make it worse. I have never had to graft anyone with SCAD, thankfully. But yeah, the VADing someone, but it's difficult. You've got terrible tissues. You've got to try and reoppose all the layers of a small vessel. It's really, really difficult. But, these ladies have ongoing problems. They're at risk for recurrence. They're at risk for, ongoing chronic pain. There's, familial clustering. There's, there is mortality related to this. Now, it's quite small, but it's there. So I think this is a very concerning clinical syndrome that I think that we again need to know a lot more about. I know here in Australia we've got the Victor Chang Cardiac Research Institute in Sydney, who are doing some work around the genetics of SCAD, particularly looking at this familial clustering. I think that is going to be really important going forward in treating SCAD better, particularly these longer term issues, because we've gotten lucky here. We've gotten lucky in that if we do nothing, things will get better. But ideally, we'd like to be able to prevent, to flag who's going to get this, but also trying to prevent these sort of long-term, morbidity-related issues.
Yes, certainly, primo non nocere really applies here. I remember I had a patient, many years ago when we knew so little about it. And of course, they all present with acute coronary syndrome. They're having chest pain. You do the arteriogram, and I remember seeing that dissection. Could see 2 lumen, dissection of the LAD all the way to the apex, and I had to send her to surgery. And even at surgery, it was really kind of tricky to find the right lumen, to make sure to put it.
I mean, that is really concerning for me. Like, if you got the whole thing, dissected, I don't think you should ever underestimate how difficult that can be and how much more trouble you can cause. And likewise with PCI, I mean, it's very easy to get in the wrong spot, and then you've got a completely infarcted anterior wall. It's a tragedy.
Easy to close that artery or even extend the dissection.
Correct. Yes.
But the presentation, this kind of a hematoma, intramural hematoma narrowing, it's very tricky. I mean, I remember maybe 10 years ago, I had a patient like that, and it was a mid-LAD, and it looked like a stenosis. And I kind of went there with a balloon, and I would balloon it, but then it wouldn't change anything. I finally just left her alone. I said, "There's nothing I can do here." And totally fine and recover. Wall motion abnormality also recovered. And we have to be so careful because it looks like their coronary arteries are so frail. I mean, it's very easy. You get in the catheter, you have to be careful the way you inject. You could really cause a dissection. And something going on, with those arteries that you mentioned, that make them really predisposed to complication.
Absolutely.
About this fibromuscular dysplasia association, and it's kind of interesting because now I'm seeing a patient, a woman who's had the 7th pregnancy, and she's starting to have problem with hypertension. Never had problem before, so I'm treating her, and I'm thinking, here's a patient that could be at risk for development of SCAD postpartum. I'm probably going to bring her back and scan her femoral arteries and the carotid arteries to see, make sure that the blood pressure is very, very well, controlled. I think that's kind of an interesting concept.
And I think for this kind of this whole topic really has highlighted for me, the real importance of that kind of multidisciplinary management of women who have or are at risk of cardiovascular disease. And, this is a really tricky one in pregnancy or around pregnancy. We probably need to play a bit better with our obstetrics colleagues to try and, help, counsel these women, but also have, a really firm plan because, during delivery is the last time you want to be facing this problem. So, we don't have a massive amount of evidence. Generally we would tend to counsel these women. We counsel a lot of women with cardiac disease to really think long and hard about pregnancy. But, I think really we definitely need a lot more information to be able to, and a lot more multidisciplinary collaboration to be able to manage them well.
I agree. So lastly, let's talk about Takotsubo. I mean, here we have these talking about patient coming with chest pain, sometimes even so dramatic that they've had even a cardiac arrest in the field. You bring them the cath lab, you have these huge ST elevation, these big T-wave inversion, you bring them to the cath lab, coronaries are completely normal.
It's a nasty surprise.
You see this ballooning, of the left end. So tell us a little bit about Takotsubo.
So I love Takotsubo. I don't, as a cardiac surgeon, I don't get involved with treating Takotsubo. I'm just utterly fascinated by the pathophysiology of this disease. I think, there's nothing like it. This really intense brain-body connection. So Takotsubo, or stress-induced cardiomyopathy, is just acute, usually apical hyperkinesis or dyskinesis, which gives this typical ballooning appearance. So as you say, you've got someone who looks for all the world like they're having an infarct, big anterior infarct, cath lab, normal coronaries, but then yes, you get this very typical, Takotsubo, the Japanese Fisher pot look to it. So really what I sort of think is quite interesting is as I said, the pathophysiology. So, we know that there is in a lot of patients a precipitating event, usually in a few hours or a few days beforehand, some sort of traumatic event. So death of a loved one. Really interesting. We've seen big increases in Takotsubo in the Christchurch earthquakes, which I think were in 2011. Flooding in Australia. I read a paper in JAMA recently that the incidence of Takotsubo during COVID with people not infected with COVID has gone up, which is understandable. There's a lot of isolation and anxiety in the world at the moment. So this causes an increase in catecholamines, particularly noradrenaline or norepinephrine, neuropeptide Y, which causes this Takotsubo. And we see it a lot in postmenopausal women. 90% of them are postmenopausal. Now, this automatically always leads to someone saying it's because they're a bit emotional and dramatic, which is not true. This is where estrogen, I think, gets really interesting, because when your estrogen is low, you get an increased sympathetic drive and increased vascular hyperreactivity. So that is thought to be the reason why we see this more often in postmenopausal women. So the catecholamine surge, the neuropeptide Y, leads to both direct myocardial effects. So we're getting direct effects, particularly at the apex, because of the high concentration of receptors for our catecholamines there, and direct coronary vascular effects, so microvascular effects, which is why we're not going to obviously pick those up on a traditional angiogram. But very, very interesting disorder. Not always benign. A lot of women will recover just fine with supportive care. But, heart failure can happen. You say cardiac arrest can happen, LV outflow tract obstruction, arrhythmias. There is a recurrence rate of 2 to 4%. That's not insignificant when you think about I think the overall incidence in the population is about 1.5 to 2%. That's, again, it's not a small number of people every year being affected by this. So very, very interesting disease. Men do get it. Men tend to have it associated with physical stress, and I've seen a couple of guys in hospital who have had it when they have been particularly in ICU with trauma or another critical illness. But yeah, I think it's just like I said, I really love this because I think it really demonstrates for me the way estrogen affects our hearts and the way our brain is connected to our physical body. Just a really fascinating disorder for me.
Yeah, I agree. I mean, I had several patients. One of those patients, the Takotsubo, the abnormal, heart function lasted only a few days. And I had another one that lasts maybe just about 2 months. They usually tend to recover within 3 to 6 months, don't they? And
yes, yeah.
But as you said, I mean, sometimes, it gets worse. I remember one of my patients, she was a wedding planner and then had to deal with the stress of her daughter getting divorced. And, talk about the stress, it was really, very, very difficult.
Very stressful.
Very stressful. And so for her, she comes to see me now. She's recovered, and stress to her every time the importance of not getting the stress getting to her, because it could happen again.
That's one of my cardiology colleagues in Sydney had a case of a woman who was a lawyer and lost a USB stick containing a really important presentation. She had Takotsubo, and I thought, God, that could be me. We've all been there. We've all lost something like that. So it was a bit of a wake-up call. I think maybe if we learn nothing from this, it's to not sweat this, not sweat everything. Just learn to relax. But no, I'm joking, of course. This is nothing to do with the emotionality that we all feel. We feel what we feel, and this is just a really. This is really about down to, chemical signaling in our bodies and in susceptible hearts. It's just really fascinating.
Very fascinating. Well, now that we're into, postmenopausal women, let's talk a little bit about, this menopause transition. What puts the women at risk, when they get into this age of menopausal transition?
I think it's really important that you say it is a transition. Menopause is the cessation of menstruation. Like, there is a defined point in time, but the process of menopause takes a period of time, and during that time, we're getting to this final permanent cessation of ovarian function. But estrogen declines over time. So usually we see estrogen levels decline over the preceding 2 years before we have the final menstrual period. And that is really important when you think about the pathophysiology of this, and will come into play later when we talk about hormone replacement therapy. So as I've sort of said a few times, estrogen, very important in cardiovascular health. It limits infarct size. It is important in endothelial function, endothelial health. It has positive effects on lipids, on blood pressure. It's anti-inflammatory. These are all very important things, as we know, in the pathophysiology, and then, of course, the prognosis and outcome of cardiovascular disease. And I think one of the really interesting things about that is we all know, it's sort of folklore and even the butt of jokes that menopausal women have these terrible hot flashes, and these are vasomotor. This is to do with vascular reactivity. But that's a really good, I think, tangible sign of the way estrogen is affecting your vasculature. Also around the time of menopause, apart from that, we know menopause can decrease the quality of life for women. It can lead to sleep disturbances, depression, and anxiety, which are all important things in our physical health, and particularly in our cardiovascular health. So usually onset menopause somewhere between 45 to 50 years of age. So in a short period of time, you lose all these protective effects, and you're losing your protective effects of HDL because you don't have estrogen driving that higher HDL. You get decreased physical activity. Now, I tried desperately to find this paper, but it's a rat study, but they induced menopause in rats through oophorectomy, and found that rats will naturally decrease their physical activity levels, just related to estrogen, not to do with aging, just related to the drop in estrogen. We do have an increase in fat gain, particularly visceral adiposity, a whole bunch of things that will contribute to a big jump in your cardiovascular risk. Now, very, very interestingly, we're going to see women who are going to have premature or early menopause. Sometimes that can be natural, as in they haven't had, a surgical or a chemically induced menopause, say from chemotherapy. But those women seem to be particularly at higher risk, particularly women who have had a medically induced menopause. So they've had a hysterectomy or oophorectomy for whatever reason. These women tend to be at higher risk for cardiovascular disease, more so than people who have undergone a natural menopause. What I also think, and this is back to my research. So I'm also a PhD candidate. My research interest is in physical activity because I don't have enough to do. So we know that increasing physical activity around the time of menopause seems to attenuate some of this risk, particularly for women who have premature menopause. So this is really fascinating, but I think it is another good example, at least for me, my research area, of how our genetics and our physiology aren't necessarily our destiny. We can absolutely modify these kinds of things. But yeah, look, menopause, huge cardiovascular risk factor, and one that we don't take into account in our traditional risk factor calculations.
Yeah, no, I agree, and it's very frustrating for the women because they say they seem to hit that age, they're in their early 50s, and they don't know why they're getting all this weight, and their cholesterol is going up, their blood pressure. And she said, I haven't done anything different, but it is this hormonal changes, and it's really kind of disconcerting sometimes,
Yes.
ladies, seeing this risk really going up. And as you mentioned, sometimes when it happens early on, usually it kind of brings about a poor later outcome, with more problems.
Yes.
Problem. It's like the phenomenon of aging is just accelerating.
It is. Yeah. Yeah, so very much is.
How could we, there's obviously hormonal therapy, particularly for women that are very symptomatic. What is safe recommendation for our patients? What should we tell them? When we use the hormonal therapy, when do we not? So give us some guidance with it.
Yeah. So look, HRT is the most commonly asked question I get, in terms of attenuating postmenopausal risk. This is where this time frame of menopause comes into play. We need to understand that. We need to be able to explain this to our patients as well. So the reason that HRT isn't it makes sense, right? We have all of this risk increasing because we've dropped estrogen. So obviously we should just give estrogen, right? That'll fix everything, but it doesn't. It doesn't because we have this time period in the perimenopausal, premenopausal phase when estrogen is declining. And during that time, risk is increasing and we're not treating it because we might not know what's happening, for example, or, there's no indication to be giving estrogen prophylactically. So the benefit for cardiovascular disease is seen when HRT is initiated early, which is within 10 years. To me, I have to be honest, like when I see that recommendation, for me, 10 years does not seem early at all. But that is my evidence-free opinion rather than my learned opinion. So I that's when we see the benefit. Now, of course, HRT is not necessarily benign for some women. And, I don't think, particularly in this context, we can't give a blanket recommendation. So if you have concerns around breast cancer risk, for example, thromboembolic disease, those things need to be taken into account. So the risk needs to outweigh the benefit. So that every woman needs to have this discussion individually with their own doctor. Now, does that mean if you can't or decide not to take HRT that you miss out on that benefit? I don't think so. And the reason I think that you can still reduce your cardiovascular risk, I think, is because we know that we have really good ability for primary prevention, independent of HRT. We have aspirin, we have statins, we have hypertension control. Diabetes treatments are getting better all the time. Like I say, a lot of my interest is in physical activity, and I know that we can get, really good outcomes in our cardiovascular risk from improving physical activity, nutrition, smoking cessation, if that's an issue. So statins, for example, really important cornerstone for me, in my mind, for treatment and primary prevention. So I think HRT, you've just got to have that discussion and think of it as not the cure for menopause. It's got to be something that you take into account, in it as all the other things that we have in our armamentarium for cardiovascular disease prevention.
Right. A very good point. So I think it's fair to say that obviously if you don't have any symptoms at all, there's no indication for HRT.
Mm-hmm.
So you got to be
Correct.
symptomatic and a lot of symptoms.
Yeah.
You got to be closer to the early menopause, the better. And you got to be, less than 60 years old, and you cannot have a cardiac event or have not had, one of those. Either we talked about SCAD, a previous MI, mm-hmm. or even DVT. The risk. Too high.
Yeah. Absolutely. Yeah. And, there are lots of ways that, we can control menopause symptoms that don't involve exposing women vulnerable women, not all women, to risks of HRT if they have those other, conditions that they're concerned about. So, I think we get, because we know that the estrogen is such a big player in this, we get so fixated that, it's such a simple step. Oh, estrogen is a problem. Let's give more estrogen. It's just not that simple. So, but it is, it's important, an important consideration.
Absolutely. So I think there's another area also that, we're not very good about past medical history, or maybe we don't pay enough attention, is on the pregnancy history.
Yeah.
When we see a patient, they're in their 40s or 50s, we don't really ask very much, what happened during pregnancy, how many pregnancies have you had, whether you had some preeclampsia, whether you had some hypertension issue during that time, or maybe even some kind of early signs of diabetes and so forth.
Correct.
Can you tell us a little bit more about, what we should be paying attention? Because a lot of times it gives us a roadmap on how that patient is,
Yes.
later on.
Yeah. So you're absolutely right. This is an area where we don't, it's a very good example of how we don't cater our cardiovascular risk assessment to women. And again, I think this has come from research that is relatively new. So pregnancy-related cardiovascular disorders, we're talking about predominantly we're talking about preeclampsia and eclampsia, or hypertension in pregnancy. We're talking about gestational diabetes. But also other things that can impact on it are recurrent pregnancy losses or miscarriages, preterm deliveries. These are all things that factor into ongoing cardiovascular risk. And I always, I sort of struggle to get this straight in my own mind. This is a bit sort of chicken and egg. Are these women going to get cardiovascular disease because they had these pregnancy disorders, or do they, is pregnancy uncovering their underlying risk? And I think it's probably the latter more than the former, but happy to be proven wrong on that. So just I guess the main thing is that, first of all, hypertension in pregnancy, so which can encompass just straight up hypertension, where you're getting elevations in your blood pressure without hematuria, and this increases your risk factor of later cardiovascular disease in at least 1.5 times. Preeclampsia is elevated blood pressure plus proteinuria after 20 weeks of gestation. Now, this is really common. This occurs into, I think it's like up to 8% of pregnancies around the world. And this is fascinating. This is a really fascinating disease. I feel terrible when I get very interested in these diseases just at a physiological level, because I know that there are actual people who have these, and please forgive me for being, just nerdy about these things, but this is all down to the placenta. This is a problem with placentation. So when the placenta is being formed, now keeping in mind that the placenta has maternal and paternal elements and maternal and fetal elements. So when the placenta, the fetal trophoblasts get into the endometrium, then it doesn't form properly. And what happens is that those blood vessels that are supposed to grow in this, process of angiogenesis, that happens poorly, and what you're left with is an ischemic kind of placenta. And so we know that when when we have organs or tissues that are ischemic, whatever they are, it kicks off a process of, endothelial reaction. So you get vasoconstriction, you get inflammation, and this becomes systemic. So you get hypertension. There is a paternal genetic contribution. So if the father has a family history of preeclampsia or hypertensive disorders, you might see that is a contribution. It's not a 50-50 contribution, but it can happen. And these are, I think, preeclampsia is a really concerning problem to have during pregnancy and then ongoing in life, because it does at least twofold increase your risk of ischemic heart disease and heart failure. And even in pregnancy, we can see cardiac effects, because we know that the natural physiology of pregnancy is that women have to increase their cardiac output by quite a lot. And they do this with, increasing your blood volume, increasing your heart rate, even your stroke volume. But in preeclampsia with hypertension, we've got this increased afterload, so you can actually worsen your LV function during pregnancy, which is obviously incredibly problematic. But these women need follow-up, and they're not followed up probably as well as they should be. As you mentioned, we just don't ask about it. And then, of course, the final sort of, think of these as three main things would be gestational diabetes. This increases risk of progression to, type 2 diabetes. We tend to diagnose this on the glucose tolerance test, which is, I've never had, but apparently the worst test you can subject somebody to. It tastes awful, allegedly, so insulin, I probably should have been an endocrinologist because I'm quite fascinated by the hormone side of this. But so, in pregnancy and early gestation, we are actually more sensitive to insulin. But then in later gestation, insulin sensitivity declines, which is driven by hormones like estrogen, progesterone, a whole bunch of placental hormones. And during that time, when your sensitivity is down, the beta cells of the pancreas become hyperplastic to try and compensate. And so as soon as you deliver, insulin sensitivity basically returns to baseline as the hormones return to sort of a more normal, non-gestating profile. But gestational diabetes tends to be in people who have pre-existing or a predisposition to beta cell dysfunction, chronic insulin resistance. Now, so when we say that, it's very easy to think of the phenotype of a patient who might have this. So someone who perhaps has a bit more visceral adiposity, who is physically inactive, all those kinds of things that we would normally associate with risks of type 2 diabetes. But it can happen in, women of any body habitus. And I think that's a really important point to take home. So we know that some of these women will convert to type 2 diabetes, and they can increase their risk of overt cardiovascular disease by at least twofold down the track. But again, this is another area where if you have had gestational diabetes, if you are meeting your physical activity requirements, not smoking, maintaining a relatively healthy body weight and visceral adiposity distribution, then your risk can be as good as someone who has never had this. So my biggest issue, and we've sort of touched on this already, is that we don't take this into account. We don't assess this. Here in Australia, we've had a lot of discussion about how to best follow these women up. Because whenever I talk about this, women will always say to me, "Oh my God, I had this. I didn't know that this was a problem." So we've looked at things like coinciding the child health checks, so whether it be for routine vaccination or just a routine check with a pediatrician or a family doctor, coinciding that with let's check mum's health at the same time, certainly flagging them for future pregnancies, that this is something that they need to be aware of. But also I think that we need to be incorporating this into our history taking as adult cardiovascular physicians. We need to be incorporating this into our risk assessment and history taking. And this is really sort of lagging behind, I think, more so than a lot of the other areas. I think a lot of people are interested and are aware of SCAD or Takotsubo and all these sorts of pathologies, but these ones, I think we're not doing as good a job as we should be.
Well, certainly, I don't know too many cardiothoracic surgeons that are first like you are in endocrinology. And I thought for a second I was in medical school, and
I'm sorry.
Endocrinology is pretty impressive. So, Nikki, could you tell us a little bit about maybe some of the research that you're conducting?
Yeah. Yeah, so as I said, my interest is in my clinical research interest is in so I'm doing my PhD in trying to use motivational techniques. So it's a psychology-based PhD, which is quite another unusual place for a cardiothoracic surgeon to find themselves. Trying to use motivational psychology to increase physical activity levels in women with or who are at risk of cardiovascular disease, with the endpoint trying to be some sort of intervention that can be rolled out sort of independent of needing to be in contact with a health service, because as people probably know, Australia is very sparsely populated. A good deal of our population lives some distance from a health service, from a hospital. So either some sort of web-based or app that women can access to increase their physical activity levels, and just really simple things like walking-based interventions. So that's my big interest. So I guess in some ways I'm trying to do myself out of a job, which I'd be very happy to do, to be honest. If my life's work means that people don't get cardiovascular disease anymore, then I'm okay with that. Some of my colleagues might disagree with me, but that's okay. But that's my interest, because even in that area, in that space, women aren't as physically active as men across the lifespan. And there's a lot of factors that go into play with that. And, this area of interest in women's heart disease has really demonstrated to me how aggressively we can manage risk factors and therefore hopefully reduce the need for interventions by aggressively managing lifestyle risk factors, which is very, very underdone. And it's another area where women aren't necessarily researched as well as they should. So I hope that by the end of my PhD I will actually have discovered something useful. But that's the beauty of doing a PhD. It could go any which way, and could go very badly. but that's all the fun, I think.
Well, I think the research is so needed. When you look at the last 20 years, we're discovering kind of maybe new things, but also discovering that we still know so little, and there's so much that needs to be done and explored, and so that kind of research is very, very important.
Yeah.
Dr. Nikki Stamp, a champion of
Thank you.
I really want to thank you for your time, and I've learned a lot. I'm going to have to kind of go back to some of my textbooks, to give you some of the phenomenal changes occurring in women during pregnancy and their lifetime. Nikki,
Amazing.
thank you very much. I appreciate you.
Thank you so much.
Have a great week.
Thank you.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.